Hi, I'm Dr. Allison Smith, head of the clinical team here at Precision Analytical, creators of the Dutch test. I'm so happy to be the one to get to walk you through a female Dutch Complete report today. Here is a fan out of the Dutch Complete with a summary page in the middle. We're going to start with that summary page. You'll notice there are some new enhancements. We have a layout to the summary page that is more comprehensive than a serum or saliva hormone test. You will notice we have a hormone production on the left and hormone metabolism on the right. On the summary page as well, we're organizing 3 hormone stories, dividing estrogens, androgens, and then cortisol. Within those 3 sections, there are 12 key Dutch test elements that are curated to tell those hormone stories. You might hear us call them the Dutch dozen. We think having them all together on the front page is what's going to help you quickly gather all the necessary insights you're going to need to develop your comprehensive treatment plans you've come to know and love from the Dutch test. You'll also find an organic acids section at the bottom of the summary page. It's kind of an alert section that gives you any abnormals to be thinking about in your patient's report. So let's start with the summary for our perimenopausal patient here. In the upper right corner, we can see this test is for a 49-year-old female. They collected their samples on cycle days 20 and 21, and we know that because the last menstrual period was April 23rd, and the samples were collected on the evening of the 12th of May and the morning of the 13th. Right? Cycle days 20 and 21 should be mid-luteal sample days if this patient has a 28-day cycle. This patient's perimenopausal, so maybe has some irregular cycles. We'll see. We'll look at the results with that in mind. First, we can see that estradiol is within the normal range, and that normal range is represented by the green arc in the dial, right? That's our premenopausal luteal range. The postmenopausal range, just for reference, is in purple, that little tiny purple band all the way to the left. So her estradiol is normal, high end of normal. Progesterone serum equivalent, though, just to the right, is very low, suggesting that this patient has not ovulated or perhaps has had an insufficient luteal progesterone output. The progesterone reported on page 1, you'll notice, is actually a progesterone serum equivalent value that's calculated from urinary alpha and beta pregnane diols. Those are reported on pages 2 and 3. So next, let's look at phase 1 metabolism. Phase 1 metabolism shows us a higher risk profile here, where the population sliders tell us that there is a shift towards the 16-hydroxys and the 4-hydroxy pathways. That's a problem. To make matters worse, phase 2 COMT methylation activity is very low. So you can see we kind of get the whole estrogen hormone story here, from production all the way through metabolism and methylation. If we move to the androgens next, we can find the DHEA here and testosterone, both within their normal green ranges for a cycling female. But when we look at the androgen metabolism, we notice right away the 5-alpha androstenediol diol is elevated, and the 5-alpha metabolism of DHEA in the slider bar shows us the 5-alpha reductase activity is high in the DHEA metabolism as well. So we might suspect this patient could be experiencing acne or hirsutism, irritability, or possibly scalp hair loss, right, with this type of lab presentation. In the cortisol section, we find the free cortisol graph shows us barely in range free cortisol levels throughout the day in their diurnal pattern, and pretty low cortisol upon waking, right? Overall low free cortisol output over the 24 hours tested. But we find this is not a low cortisol production issue, because we can see metabolized cortisol is actually high. And this changes our cortisol assessment quite a bit. The high cortisol clearance rate tells us that cortisol is breaking down pretty quickly in tissues, and the body is working hard to limit access to free cortisol in the face of high cortisol production. That's really what this is telling us. This is a body desperately trying to adapt to stress. In the OATS alert section, we can see B12 and B6 deficiencies are noted, a gut etiology perhaps, maybe dysbiosis or maldigestion, neuroinflammation, and low melatonin is also noted. So some of these underlying issues could be driving the estrogen metabolism problems, the 5-alpha reductase activity, and maybe even that fast cortisol clearance. We got all that from the Dutch Complete summary page. So everything else will be icing on the cake probably. Let's dive into the next section, the sex hormones panel. Here it is. Page 2 visually displays the pathway flows for the sex hormones and the androgens. And page 3, you'll find the list of findings, but we're going to focus on the pathway flows on page 2. In the upper right corner, we find the progesterone metabolites. They're both lower than luteal and even falling into the menopausal ranges. We saw the serum equivalent on page 1. These are the analytes that are used to calculate that progesterone serum equivalent. But it's the alpha pregnanediol in particular that informs us about progesterone's potential neurosteroid activity in the brain and how its potential to bind GABA receptors and make us feel nice and relaxed. Here we can see this patient's 5-alpha metabolism of progesterone is kind of toward the higher side. And this is a new visual element on the Dutch test. Someone with a predominant 5-alpha metabolism may feel more relaxed with lower doses of progesterone when using it for the purpose of sleep or mood support. So this is kind of the benefit of looking at that 5-alpha metabolism of progesterone before putting someone on progesterone therapy. Now, parent estrogens in this case are sitting within their ranges, but on the higher side. Right? Progesterone metabolites were pretty low for a cycling female. This could be due to irregular cycles in perimenopause or even anovulatory cycling, which is pretty common in late perimenopause. And patients may have estrogen dominance symptoms with this type of lab presentations, and it might feel like heavy bleeding, mood swings, breast tenderness, things like that. Now that we know that she's a bit estrogen dominant, we want to use the population sliders to assess her phase 1 estrogen metabolism. And here we see a strong preference towards the 16-hydroxyestrone and the 4-hydroxyestrone when each are compared to the 2-hydroxy. And this represents a higher risk metabolic profile. You can find the actual 2:16 and 2:4 ratios plus their ranges that inform these population percentile sliders on page 3 in the sex hormone results table, if you like to look at those ratios. The methylation activity population slider is telling us about phase 2 methylation. So we know she favors some of the bad stuff. Is she methylating well? And the answer in this case is no, she's not methylating very well. For this patient, when we compare her to methoxy E1 to the 2-hydroxy E1, we can see she falls very low in the population percentile. Most people methylate better than she does. In the androgens, we see total DHEA production here. This is a new element on the sex hormone panel page here. We've pulled the total DHEA dial onto the androgen section. It is still the sum of DHEA sulfate, androsterone, and etiocholanolone. Notice that the DHEA sulfate is relatively low compared to its downstream tissue metabolite, androsterone, and also low compared to the total DHEA production. This is actually a common finding with inflammation and insulin resistance. The 5-alpha metabolism population slider here confirms DHEA's metabolic preference, so those strong tissue androgens. So pretty androgenic picture here. Testosterone is within range for a cycling female, but its 5-alpha reductase metabolite, 5-alpha androstenediol is high. This is all stuff that we gleaned already from the summary page. So let's move to the adrenal panel next. Page 4 is the visual representation of the cortisol data now, comes before the table list of findings on page 5. Let's look at free cortisol patterns first. Free cortisol and free cortisone diurnal patterns are similarly hugging the bottom of their ranges throughout the day, and at some points fall below the normal range. And when we add all those points together, we can see we have a pretty low total free cortisol. We do see the high metabolized cortisol, and the fact that the metabolites are high informs us that the cortisol production and clearance is high, and the low free cortisols are actually maybe part of an adapted stress state. So if we would have just tested the free cortisols, we would have thought, gosh, this patient has low cortisol output, but that would have been an incorrect assessment. The true assessment is that cortisol production is high, and the low free cortisols are an adaptation to high cortisol production. Common causes of high cortisol clearance rate are insulin resistance and inflammation. So we already know we want to start turning over some stones in that direction. The systemic preference population slider represents the relative balance between cortisol metabolites and cortisone metabolites that are formed in the liver and adipose tissues. It is normal in this case, maybe shifting a little to the left. A shift to the right towards cortisol or THF represents acute stressors and that short burst cortisol activation, while a shift to the left or towards cortisone or THE, like in this case, could represent a chronic stress kind of body adaptation to long-term high cortisol exposure. Melatonin comes from the waking sample. All of the waking samples contain the hormones that were produced, circulated, and excreted during the night while the patient slept. And for melatonin, this should be the time of highest production. So this patient has a very low overnight melatonin production. Could be a problem. And finally, the organic acids bring up the tail of the report, and we already know what we'll find because the summary page told us all about this person's deficiencies and gut issues. But here they are as they'll be found on page 6. We do use methylmalonate to tell us about B12 deficiencies deep in the mitochondria. Xanthuronate and kynurenate elevations tell us about B6 deficiencies. High indican is our marker suggestive of dysbiosis or maldigestion. HVA and VMA are kind of interesting markers that can inform about sympathetic nervous system activation and neurotransmitter clearance. Both of these metabolites sit on the other side of a COMT methylation step, and they tend to mirror adrenal output as well. So these are important to look at in the context of adrenal function and COMT methylation activity. Several markers of oxidative stress and inflammation can help you zero in on those causes of maybe cortisol elevations or estrogen detox abnormalities. This patient's quinolinate was high, which made us think about neuroinflammation as being a driver in particular. And melatonin we report in the context of the diurnal cortisol on adrenal page 4, but you'll also find it here on page 6. Don't forget to use our new About Your Results comments section. It's full of patient-specific comments that are designed to make your life easier. So use them. With these, you can quickly identify those abnormals and really any underlying hormone symptom drivers and synthesize them into easy-to-read comments. We call this section the Dutch Dozen, and these comments really help you interpret the findings, mostly on the summary page in particular. And we think you'll love using them. They're distilled, simplified. You can feel confident basing your assessment on these 12 key concepts, plus the oats, and get to the fun part, which is designing the treatment plan a little bit faster. With the Advanced Insights section following the Dutch Dozen, you can dig deeper to identify advanced patterns within the report if they exist. Those deeper level concepts that may not be pertinent in every case, but those you should consider for some, like sulfation of DHEA that we saw in this case, or cortisol-cortisone balance. This is all covered in the Advanced Insights section. And similar to the Dutch Dozen, they're all grouped by the hormone story to which they belong: estrogens, androgens, and cortisol. Our goal with the new summary page of the Dutch Complete is to give you a person's complete hormone story, along with that deeper understanding of all of the etiological issues that could be underlying, all on one page, simply and comprehensively. I hope you discover all of our provider resources. The Dutch Interpretive Guide is an incredible resource that walks you through collection to interpretation for all Dutch reports. There's valuable information in there on common patterns and even some treatment pearls. The mini guides dive into condition specifics. So if you tend to see a lot of endometriosis or work with male infertility, we have mini guides that can help guide you through Dutch testing and get into some treatment options. Our treatment guide gives you a multitude of ideas for treating highs, lows, and patterns found on a Dutch test. As a provider, you have access to all of our clinical resources, courses, and consults. Thank you for learning about our new Dutch report enhancements and the new Dutch Complete. I hope you feel ready to use this with your next patient.